Pain is real. But here's what most people get wrong, and what the neuroscience now shows clearly. The amount of pain you feel does not equal the amount of damage in your tissues. Chronic pain is not a broken bone that refuses to heal. It's an alarm system that got stuck in the on position. Welcome to Longevity Lab. I'm Claire.
And I'm Robert. Claire, I have to say, I've lived with a cranky lower back for almost 15 years now, and I've been telling myself the same story the whole time. There must be something still physically wrong in there. That's what every doctor visit seemed to suggest.
And that's exactly why today's episode matters so much. We're going to talk about the neuroscience of chronic pain, specifically something called central sensitization, and what the research actually shows about how to calm a hypersensitive nervous system without reaching for another pill bottle.
I need this one. 15 years of avoiding certain movements because I was afraid of making the damage worse. If what you're saying is true, I may have been protecting an injury that already healed a decade ago.
That's precisely the conversation we're having today. And Robert, you're not alone in that pattern. Roughly 1 in 5 adults lives with chronic pain. In the United States alone, that's more than 50 million people. And the economic cost is staggering. Over $600 billion a year in medical care and lost productivity. That's more than heart disease and cancer combined.
More than heart disease and cancer combined? That number alone should be making headlines every single day. So what are we getting wrong, Claire?
Let's start with the central myth. Most of us were taught, implicitly or explicitly, that pain is a direct readout of tissue damage. Something hurts because something is structurally wrong. A torn ligament sends a signal up to the brain. The brain registers pain, and when the ligament heals, the pain stops.
Right. That's the mental model I've had my entire life. Break a bone, it hurts. Bone heals, pain goes away. Simple.
That model works reasonably well for acute pain. If you sprain your ankle today, the pain is doing an important job. It's forcing you to protect the area while it heals. But here's where the science has fundamentally changed our understanding. Pain is not actually a signal that travels from your tissues to your brain. Pain is an output of the brain. It's a decision the brain makes based on a whole range of inputs about whether you are in danger.
Wait, hold on. So the pain I feel in my lower back isn't coming from my lower back? It's coming from my brain?
Not exactly coming from your brain. Your brain is producing the experience of pain as a protective response. Think of it like a home security system. The sensors on your windows and doors are like your nerve endings. They detect signals. We call that nociception, which is the detection of potentially harmful stimuli. But the sensors don't decide whether the alarm goes off. The central control panel does. And the control panel weighs everything, not just the sensor readings, but the time of day past break-ins. Whether you're home alone, whether you just watched a scary news story about neighborhood crime.
So the alarm might go off even if a raccoon is just rustling in the bushes?
Exactly. And this is the crux of the whole episode. A raccoon in the bushes is not a real threat, but if the system is sensitive enough, the alarm blares anyway. In the body, that's what happens in chronic pain. The tissue can be fully healed, no structural damage left, but the brain's alarm system has become hypersensitive. It keeps producing pain because it has learned at a deep neurological level that the body is in danger.
That is genuinely hard to wrap my head around. Because when I bend over to tie my shoes and my back grabs, the pain feels like it's right there in my spine. It doesn't feel like a decision my brain is making.
And that's exactly why chronic pain is so difficult to live with. The experience is real. I want to be crystal clear about that. This is not saying the pain is imaginary or all in your head. The pain is 100% real. What we're saying is that the source of the pain has shifted. In acute pain, the source is tissue damage. In chronic pain, the source is often a sensitized nervous system.
Okay, so walk me through that shift. How does a normal pain signal become this stuck alarm system?
This brings us to the mechanism of central sensitization. And this is where I want to get specific because understanding the biology is what gives people true agency over their pain. The term central sensitization was first formally defined by the International Association for the Study of Pain, and it describes a state where neurons in the central nervous system, the spinal cord and brain, become hyperexcitable. They start firing more easily, firing more intensely, and firing in response to stimuli that wouldn't normally trigger them.
So it's like turning up the volume knob on the whole nervous system.
That's a great analogy. Imagine you're at a concert and the music is painfully loud. You leave, but for hours afterward, your ears are still ringing. Normal sounds feel harsh. The auditory system has temporarily upregulated its sensitivity. Central sensitization is a similar phenomenon, but in the pain pathways, and instead of lasting hours, it can last months or years.
And what causes the nervous system to turn up that volume in the first place?
Often it starts with an acute injury. Let's say you hurt your back. The initial tissue damage sends a barrage of danger signals up to the spinal cord and brain. That's appropriate. It's teaching your system to protect the injured area. But in some people, the nervous system doesn't return to baseline after the tissue heals. The neurons in the dorsal horn of the spinal cord become sensitized. They start amplifying signals instead of just transmitting them. Glial cells, the support cells of the nervous system, become activated and release pro-inflammatory molecules that keep the amplification going. The brain's descending pain modulation system, which normally acts like a brake pedal, becomes less effective. So the system is simultaneously amplifying danger signals and losing its ability to dampen them down.
So it's not just one thing going wrong, it's multiple layers of the nervous system getting stuck in a state of high alert.
Exactly. And this is why chronic pain is now understood as a disease of the nervous system, not just a symptom of an ongoing injury. The tissues often look completely normal on an MRI. Actually, and this is a really important point, scan findings don't predict pain very well at all. Studies have shown that a huge percentage of people with no back pain have disc bulges, disc degeneration, and even herniations on their MRI scans. A landmark systematic review found that by age 40, roughly half of people without any back pain have disc degeneration on imaging. By age 60, it's more like 90%.
90% of pain-free 60-year-olds have disc degeneration. So the MRI findings I've probably been carrying around in my head for 15 years explain nothing?
They might explain very little. And here's the danger. When someone gets an MRI and is told they have a bulging disc or degenerative changes, that information itself can increase their pain. There's actually research on this. Notifying people about incidental findings on imaging is associated with worse outcomes, more disability, and more pain. The label becomes part of the problem. It feeds the brain's danger assessment.
That is infuriating. I've probably had doctors point to exactly those findings and say, "There's your problem." And the whole time, my brain was taking that as evidence that my back was fragile and broken.
And that belief, my back is fragile and broken, is itself a driver of pain. This is where the cognitive and emotional pieces become critical. The brain's pain output depends on more than just nociceptive input. It depends on your beliefs, your expectations, your past experiences, your stress levels, your sleep quality, your social context. All of those factors feed into the brain's danger assessment. When the brain concludes the body is in danger, it produces pain. When it concludes the body is safe, it doesn't.
So if my brain believes my back is fragile every time I bend over, it's producing pain, partly because it thinks that movement is dangerous.
That's the model. And animal research supports this. There are fascinating experiments showing that when animals are injured while under conditions of stress or fear, their pain responses are much larger and last much longer than when they're injured in a calm, safe environment. Same injury, different context, different brain assessment, different pain experience.
That's wild. And it explains a lot about why stress at work seems to make everything hurt more.
It absolutely does. Stress hormones like cortisol and adrenaline feed directly into the threat detection circuitry. Chronic stress primes the nervous system for pain. Poor sleep does too, and there's a well documented bidirectional relationship where pain disrupts sleep and poor sleep amplifies pain.
So, what I'm hearing is that chronic pain is this whole body, whole brain phenomenon, and we've been treating it like a simple mechanical problem. Find the broken part, fix the broken part. But the broken part was never the real issue.
And this brings us to the mainstream medical response. For decades, the default approach to chronic pain has been pharmaceutical, largely opioids. And here's the painful irony. Opioids work reasonably well for acute pain in the short term, but for chronic pain, the evidence is much weaker and the risks are substantial. Long term opioid use can actually make pain worse through a phenomenon called opioid induced hyperalgesia. The nervous system compensates for the drug by becoming even more sensitive. Plus, the risk of dependence, tolerance, and the overdose crisis we've all heard about.
I remember when doctors were handing out opioids for everything. It seemed like the easy answer at the time. Now we're living with the consequences.
The research community has had a reckoning on this. The consensus now is that opioids have a very limited role in chronic non cancer pain, and the more important shift is toward non pharmacological approaches that target the actual drivers of central sensitization. That's where the real hope lies. And look, I want to be careful here. If someone is currently on opioid medications, they should absolutely not stop abruptly. That's a conversation to have with their doctor. Gradual tapering under medical supervision is the safe path.
Of course. So if pills aren't the answer, what actually works? Because a lot of people are living with real daily pain right now, and they need something concrete.
Let's start with the one with the strongest evidence base. And this one is going to feel counterintuitive, Robert, because it directly contradicts the old advice to rest and avoid movement. The evidence shows that graded exercise, meaning physical activity that starts gently and builds up gradually, is one of the most effective treatments for chronic pain, not just as a general health measure, but as a direct pain relieving intervention.
Exercise for pain relief. I have to tell you, every instinct in my body says the opposite. When my back hurts, the last thing I want to do is move.
And that instinct is completely understandable. But here's what happens when you avoid movement for prolonged periods. Your muscles weaken, your joints stiffen, your cardiovascular fitness declines. Your brain gets even less evidence that the body is safe and capable. The deconditioning makes every movement harder, which makes activity feel more threatening, which increases the brain's danger assessment, which increases pain. It's a vicious cycle. Rest feels protective in the moment but feeds the problem over time.
So the old advice, stay in bed until your back settles down, was actually making people worse?
For acute injuries, a brief period of relative rest, 1 or 2 days, can be appropriate. But for chronic pain, prolonged rest is counterproductive, and the evidence is overwhelming. The Lancet published a major series on low back pain in 2018 that reviewed the global evidence base, and the conclusion was clear. Exercise is the first-line treatment. Multiple systematic reviews and meta-analyses show that exercise reduces pain and improves function in chronic low back pain, osteoarthritis, fibromyalgia, and chronic widespread pain. And the effects aren't just physical.
What do you mean? the effects aren't just physical.
Exercise changes the nervous system. It provides the brain with evidence that the body can move, can load, can tolerate activity. It releases endorphins and other endogenous opioids, your body's own pain relieving chemicals. It reduces systemic inflammation. It improves mood and sleep. It downregulates the stress response. All of those effects directly counteract central sensitization. And there's neuroimaging research showing that regular exercise actually alters pain processing in the brain. It strengthens the descending inhibitory pathways, the brake pedal I mentioned earlier.
So exercise literally rewires the pain system.
That's exactly right. Now, the key word here is graded. You don't go from sitting on the couch to running a marathon. You start at a level that feels manageable, even if it's just a 5-minute walk, and you build up very slowly. The goal is to teach the brain over weeks and months that movement is safe. Pacing is essential. Pushing through severe pain can actually reinforce the threat response and set you back.
And what does the research say about how much exercise? If someone asks you for a specific prescription, what do you tell them?
The general recommendation is about 150 minutes of moderate intensity aerobic activity per week, plus strength training twice a week. But for someone with chronic pain, that may need to be broken into much smaller chunks, 10 minutes here, 15 minutes there. What matters most is consistency and gradual progression. A 2022 meta-analysis in the British Journal of Sports Medicine looked at exercise for chronic low back pain and found that the sweet spot is typically 3 to 5 sessions per week, each lasting 30 to 60 minutes, combining aerobic activity with some form of strength or motor control work. But those are targets to build toward, not the starting line.
That's helpful. But let me be honest, Claire. Some days the pain is so bad that the idea of any exercise feels impossible. What do you say to someone in that situation?
I say start smaller. On a high pain day, maybe the goal is just to walk to the mailbox, or do some gentle range of motion movements in bed, or practice slow diaphragmatic breathing for 5 minutes. The principle is to avoid complete immobility and to keep sending the brain small, safe signals of movement. Consistency matters more than intensity. And of course, if someone has a new or worsening pain, or pain with red flag symptoms, that absolutely warrants a medical evaluation before starting an exercise program.
Okay, so exercise is the big one. What else does the evidence support?
The second major pillar is psychologically informed approaches, and at the top of that list is cognitive behavioral therapy, or CBT. This is not about telling someone their pain is imaginary. It's about working with the thoughts, emotions, and behaviors that feed central sensitization.
So how does CBT actually reduce pain? What's the mechanism?
Think back to what we said about the brain's danger assessment. Pain is produced when the brain concludes the body is under threat. CBT works directly on that calculus. It helps people identify catastrophic thoughts. My back is broken. I'll never be able to do anything again, and build more accurate, less threatening interpretations. It helps people gradually re-engage with activities they've been avoiding. It teaches skills for managing stress, anxiety, and depression, which are huge amplifiers of chronic pain.
And there's actual evidence that this reduces pain, not just that it makes people feel better about being in pain.
There is. A large Cochrane review found that CBT produces small to moderate improvements in pain intensity, disability, and quality of life for people with chronic pain. Another key meta-analysis found similar effects, and importantly, the benefits seem to last after treatment ends. Because CBT doesn't just mask the pain, it changes the underlying neural processing. Brain imaging studies show that CBT alters activity in regions like the prefrontal cortex and the amygdala, areas involved in pain modulation and threat processing.
So it's literally rewiring the brain just like exercise.
Different pathways, Same principle. And there's a related approach I want to mention: pain neuroscience education. This is what we've been doing in this episode. Simply understanding that pain is a brain output, that tissues can heal while the alarm system stays stuck, that scan findings often don't explain symptoms, that knowledge alone has measurable effects. A systematic review found that pain neuroscience education reduces pain and disability, especially when combined with exercise. When people understand that movement is safe, they move more. And movement is medicine.
That makes so much sense. I think most people with chronic pain have never had anyone explain the neuroscience to them. They've been told to rest, take pills, and avoid things. Nobody explained why their pain persists after healing, or that their own nervous system is the key player now.
And that education gap is a massive missed opportunity. There's also growing evidence for mindfulness based stress reduction and acceptance and commitment therapy. These approaches train people to observe their pain without the layer of catastrophic fear that amplifies it. A 2019 meta analysis in the journal Pain found that mindfulness based interventions significantly reduced pain intensity and improved quality of life for chronic pain patients, especially those with fibromyalgia and low back pain.
I've dabbled with meditation, but never understood why it might help with actual physical pain. Now it clicks. It's calming the threat detection system, not just relaxing.
Exactly. Now let's talk about the third evidence based tool, acupuncture. This one surprises a lot of people because acupuncture has traditionally been framed in terms of meridian theory and energy flow, which sounds very unscientific to Western ears.
Right. I've always been skeptical. Is acupuncture actually supported by good research?
And here's the finding that surprised me most when I first came across it. The most rigorous individual patient data meta analysis was published in the Journal of Pain in 2018 by Andrew Vickers and colleagues. They analyzed nearly 21,000 patients from 39 high quality randomized trials, and they found that acupuncture was significantly more effective than both sham acupuncture and no acupuncture controls for chronic pain conditions: back pain, neck pain, osteoarthritis, headache, and shoulder pain. The effect size was clinically meaningful.
Significantly better than sham? That's important because I always assumed any benefit from acupuncture was just placebo.
And here's the nuance: acupuncture was better than sham, but sham acupuncture also produced substantial pain relief, which tells us that part of acupuncture's effect comes from the ritual, the expectation, the therapeutic relationship, but there appears to be a specific effect beyond that as well. Mechanistically, needle insertion triggers local release of adenosine and endogenous opioids, and it modulates activity in brain regions involved in pain processing. Neuroimaging studies show that acupuncture alters connectivity in the brain's default mode network and other pain related networks in ways that differ from sham needling.
So, the needles themselves do something real at the nervous system level?
The evidence suggests they do, and it aligns with our central sensitization framework. Acupuncture may be working in part by providing novel sensory input that competes with and modulates the pain signal at the spinal and supraspinal levels, a kind of gate control effect combined with descending pain modulation. The needles aren't repairing anything structurally, they're communicating with the nervous system.
That's a fascinating reframe. And the bottom line for someone listening: acupuncture is a legitimate evidence based option for chronic pain, not just an ancient tradition.
It's a legitimate option. The key caveat is that it should be delivered by a trained, licensed professional using sterile, single use needles. And the effects, while real, are modest on average. It works best as part of a broader approach that includes exercise and psychologically informed care, not as a standalone cure.
So we've got three big tools: graded exercise, CBT or pain neuroscience education, and acupuncture. What about other things people try? Anti inflammatory diets, supplements, CBD, that kind of thing.
Good question. Let's talk about what the evidence says. Anti inflammatory dietary patterns, the Mediterranean diet, for example, show modest benefits for some chronic pain conditions, likely through reducing systemic inflammation, which feeds central sensitization. There's decent evidence for omega 3 fatty acids in inflammatory pain, but the effect sizes are smaller than exercise or psychological approaches. Supplements like glucosamine and chondroitin, which were huge a decade ago, have not held up well in rigorous trials. CBD has genuine biological plausibility and some promising early data, but the evidence base is not yet strong enough for a blanket recommendation. What I'd say is I focus on the big three first. Those are the interventions with the strongest, most consistent evidence.
So, if someone only has energy to make one change, it's exercise.
Graded exercise is the foundation. If I could only prescribe one thing, that would be it. The research is unambiguous. Not aggressive training, gentle, consistent, progressive movement, and for anyone with a medical condition or severe pain, working with a physical therapist or a pain specialist to design an appropriate program is absolutely the right move.
Let me make sure I have the mechanism straight. Chronic pain is often not tissue damage. It's a nervous system that has become stuck in a state of high alert, central sensitization. The brain keeps producing pain because it believes the body is in danger. Rest and avoidance make it worse by deconditioning the body and confirming the brain's threat assessment. Exercise, CBT, and acupuncture all work by retraining the nervous system to feel safe again.
That's a remarkably good summary, Robert. And I want to add one thing about pacing. People with chronic pain often fall into a boom and bust cycle. They push through on good days, crash on bad days, and the unpredictability feeds anxiety and pain. Pacing means spreading activity evenly across the week, keeping a steady, sustainable level of activity regardless of how you feel that day. It's one of the most practical skills taught in pain management programs.
That's a really concrete tip. Instead of good day, mow the whole lawn. It's mow a section, do a bit every day.
Haha, exactly. And here's another specific takeaway from the research. Sleep is a major modifiable factor in central sensitization. Chronic sleep deprivation lowers pain thresholds and amplifies the brain's threat response. Prioritizing consistent sleep, same bedtime, same wake time, dark, cool room, no screens before bed is a real evidence based pain management strategy. A 2023 systematic review found that improving sleep quality was associated with clinically meaningful reductions in pain intensity for people with chronic pain.
I've definitely noticed that a bad night's sleep makes everything hurt more the next day, but I never connected it to the brain's danger assessment before.
That bidirectional relationship is one of the most consistent findings in the pain literature. Pain disrupts sleep, and poor sleep amplifies pain. Breaking that cycle on either side helps.
Okay, Claire, I want to circle back to something you said earlier about the brain producing pain as a protective output. That reframing alone feels life changing. For 15 years, I've been treating my back as a broken machine. Every twinge made me think, oh no, more damage. And now I'm realizing that every twinge has been reinforcing the brain's belief that I'm fragile. The fear was part of the pain.
And that insight is the beginning of recovery for a lot of people. The fear avoidance model of chronic pain, developed back in the 1980s, predicted exactly this. People who interpret pain as damage become fearful, they avoid movement, they become deconditioned, and the pain intensifies. People who interpret pain as a sensitized alarm system move more, fear less, and over time, their pain decreases. It's not a quick fix. Neuroplasticity works both ways. The brain took time to learn the pain pattern, and it takes time to unlearn it. But the brain is plastic at every age, change is possible.
That's the hopeful message. It's not about gritting your teeth through pain. It's about gradually teaching your nervous system that you're safe.
And safe is the operative word. Every evidence based treatment for chronic pain, exercise, CBT, pain neuroscience education, acupuncture, sleep improvement, stress management ultimately does the same thing. It signals safety to a nervous system that has been stuck in threat mode.
I want to ask about one more thing because I know people will wonder. What about over the counter painkillers? NSAIDs, acetaminophen, is taking those a problem?
For occasional use, they're reasonable short term tools, but long term daily use carries risks, gastrointestinal bleeding, kidney damage, cardiovascular effects, and importantly, they don't address the central sensitization mechanism. They reduce the nociceptive input from peripheral tissues, but the brain's alarm system stays sensitized. So they give temporary relief while the underlying problem persists. That's why the guidelines increasingly emphasize non pharmacological approaches as first line treatment for chronic pain.
That's a clear answer. So the toolkit is graded movement, working with your thoughts and beliefs, maybe acupuncture, and foundational health behaviors like sleep and stress management. And the common thread is calming the nervous system.
That's the entire episode in 3 sentences. And today's rule I want listeners to remember: pain is a protector, not a damage meter. When pain persists after healing, the goal isn't to fix the tissue, it's to retrain the alarm system.
And that's genuinely empowering. It means I'm not broken. My alarm system is just stuck, and there are concrete evidence based ways to recalibrate it.
If you live with chronic pain, please do consult with a healthcare professional, ideally a pain specialist or physical therapist who understands modern pain neuroscience, before making major changes. But know this: the brain that learned to amplify pain can also learn to quiet it down.
That's a note of real optimism to end on. Claire, thank you for this. I think a lot of people are going to hear themselves in this conversation.
Thank you for being the audience's voice today, Robert. And thank you for listening to Longevity Lab. If this episode helped you see pain differently, share it with someone who needs to hear it. New episodes every day. Subscribe and hit the bell.
And we'll see you next time.